Welcome to the Jerry Powell podcast. Are you supposed to say something now, Alex, or is it me?
It's you. You forgot our intro.
I forgot our intro. No!
It's pretty good.
This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us
Today, we have Aanand Naik, who is acting chief.
He's here, too.
He's right there. Right there. Look, hello on video.
If you pull him up on our YouTube video, you could actually see him.
He's acting chief at HSR&D at the VA Medical Center in Houston and the Baylor College of Medicine. Welcome to the Jerry Powell podcast.
Thank you.
We usually start, I'm going to try to remember the format. We usually start off with a song request. Do you have a song for Alex before we start getting into... This is actually a combined Jerry Powell JAGS podcast. We'll be talking about one of your papers. But before we do that, got a song.
Well, I told Alex, since I'm a Texan coming to San Francisco, I should request the Gun Song by Lumineers.
Right now, is that because, as a Texan, you own a gun?
I actually don't own a gun.
You don't own a single
song, I don't
gun?
own a single gun.
Not a single gun?
No.
Ah, okay.
But I have many friends and family with too many guns.
With too many guns.
Do you travel with some Texas dirt wherever you go, just in case? You always...
No. Sometimes I bring my boots. I didn't this time, though.
All right, Alex, give us a little bit.
I don't own a single gun, but if I did, you'd be the one. Hold it, aim it, make all of the bad men run, but I don't own a single gun. La 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 la.
That was lovely.
Thanks. Yeah, a little bit. Got the la in the wrong octave, but that's all right. It's close enough. That was the last concert you saw?
That was the last concert.
Yeah.
Last two concerts.
Good concert. Oh, really?
Yeah.
You must like them.
I do like them.
I really enjoyed this song. It's like, oh, I should check out more of the Lumineers. I haven't really, other than what's played on the radio, I haven't really listened to them.
Yeah, I feel like every other song is Bob Dylan that we play here. So
that's true. We do a lot of Bob Dylan. We do a lot of Iron and Wine. We've done a lot of Beatles.
A lot of Beatles.
Mm-hmm. Interesting. No Grateful Dead.
Huh?
We've done a fair amount of Tom Petty. Yeah. It's kind of a grouping amongst Jerry Powell folks.
What are we here to talk about again?
Oh, yeah. What are we talking about? Something about patient priorities.
That's right.
Health priorities. So,
I mean, part of this was also instigated. You had a JAGS article that came out just a couple months ago on the development of clinically feasible process for identifying individual health priorities. Maybe before we actually go into this topic, maybe we can just do a big rewind to talk about how you got interested in this topic of, I guess, identifying healthcare priorities.
Yeah. So I guess going really far back, like all of us in residency program, the people who get the most attention are sometimes the ones who kind of find fascinomas and rare diseases and treatments for that. And I was always just more fascinated with these patients who have like hypertension, diabetes, CHF, COPD all at once, right? So, and that they would just keep coming back to the hospital and we'd have a hard time taking care of them, and we've got to do better. And if you actually sit down and talk to them, you realize that they can't manage all the things that we're asking them to do. It's both physically, cognitively, functionally impossible, and we're not addressing the things that they care about. And so I think, as from just being a fellow resident, just got interested in kind of the care of these complex, multi-morbid older adults. So obviously that's why I became a geriatrician. And then thinking about the approach that we take to to take care of these patients, and we focus on again these diseases and multiple guidelines, and that wasn't the right way to approach it. So I think just from the very beginning, it's sort of a search for how do we identify what patients care about the most and what their healthcare should be about, and not to ignore science and diseases and evidence, but to use it towards the improvement of what patients say they want to get to, not what the guidelines say alone.
So this is like a core Jerry Pal type of topic here. We're talking about older adults with multiple chronic conditions, maybe with some cognitive impairment and functional impairment, and we're talking about sort of trying to figure out what their health priorities are.
Yeah.
Is that the idea?
Yeah.
So here's a question. Isn't that what's happening in palliative care with people who are sort of seriously ill, nearing the end of life? Haven't we already developed these techniques for eliciting goals of care?
Yeah, so that's a point in a conversation I get into a lot. So I'll channel my best Mary Tinetti here and say there isn't a conflict here between a palliative care approach and this, but I think we're talking actually about different patient populations a little bit. Actually, the best example of this is actually in Gawande's most recent book, and when he talks about his father's illness course, and he says, as his father was having closer to the end of life, his scope would narrow, and they get focused on just end of life goals, and the perspectives was very narrow. Mm-hmm. And I think that the end of life trajectory made it easier to talk about goals of care, and because it was very specific and sharp and acute and pointed. But the patients we're talking about actually have a wider scope of goals and a wider scope of things that they want to accomplish, and it's a much bigger avenue, and they're not really thinking about their death. They often don't want to think about their death. And we have a hard time actually telling them when their death might be. So really this is about focusing on a set of outcome states or activities or things that they want to do that are much broader and wider than I think what we see in traditional palliative care. It's harder to actually engage in this conversation with this population because you don't have that end of life or that sort of serious illness scope that narrows the perspective.
Yeah, it's a focusing, knowing that death is imminent, or that sort of awareness.
Or even the single serious, even if death isn't imminent, the single serious illness that focuses your attention on what's most important. I think you have those forces in palliative care that you don't have in a little bit less, they're not really younger, but a little bit less severely ill population.
And there are those who would, and I think ourselves included, who would say that there's tremendous overlap between geriatrics and palliative care, and these patients would probably also be they'd be considered geriatric patients. They'd be considered palliative care patients as well. I wonder how do you respond to the critique that can't we just take the tools that we use near to the end of life and then move them upstream, or do we need to start from scratch and develop new tools?
No, I think that there's a lot of similarity and overlap. I don't deny that at all. And I think that there's probably, in the conversations that we've had with palliative care experts, I think there is similarity in some of the tools.
I got to say, though, even when I do inpatient consults, I find it actually much easier than thinking about how to have these goals of care conversations, even in nursing home patients who are not very sick. Or who have like some multimorbidity, but there's no triggering event where you just have to, where you have to have this conversation with them, but there's not that nidus, there's not that, that, what do you call it when a crystal develops the...
Oh, yeah. You mean like scratch the glass and then you get that nucleation process?
Nucleation process.
And then you develop the crystal around that?
It's often a challenge, and that's something that I work with a fellow on a panel of nursing home patients, and I think the hard part is that those goals of care talks are often fall lower in the priority because there's nothing that kind of stimulates those discussions.
The driving decisions.
Quite like a hospitalization or a new diagnosis of something really bad, potentially.
So the trigger often in this case is actually the the burden that falls on these patients. So just the number of visits they have to go to, the number of medications they have, all the activities you expect them to do. That's often a first entry into this. So how are you struggling with your care, and what do you find burdensome? That's sometimes the way that we approach it. The other way that I've approached it, and maybe this isn't so different from a palliative care either, is actually starting by exploring value. So again, early in my journey, we started asking about goals. And I think patients just had a real struggle with what is that?
Right. So too abstract, right?
Too abstract, too nebulous. My doctors never talked to me about goals before. Why are we talking about this? That has nothing to do with my medical care. So I actually found it really hard in early work to kind of get goals conversations going. So sometimes it'd be a little bit easier in single disease conversations. So some of the early work was in diabetes or hypertension just specifically. Not in multimorbidity, because it was a little easier to have goals conversations in that context. But more recently, with actually some clinical psychology colleagues, Lillian Dindau, Jennifer Moye, Michelle Carroll, just appropriately give credit to people, have helped me think about this process of thinking about values. And that values are actually something that everyone has an easier time kind of coming to grasp with it. What is most important to you? If you weren't feeling pain, or if you weren't short of breath, what would you be doing more of? And those are the kind of valued activities. And through some qualitative work we've done in other papers published in JAGS, we really identified that older multimorbid patients have a set of values, a kind of values families that are relevant to healthcare. So social, spiritual connection, independence, function, valued life activities or abilities, balancing mortality and morbidity. So balancing the kind of I want to live longer versus I want to manage my quality of life or symptoms. And then to the degree I want to be engaged in care or more passive. So those are sort of 5 values categories. And we found that they're actually all important to people. It just sort of depends on the day or the circumstances about which kind of is most salient. But these are all sort of important things, and that's how you can construct goals from individualized, specific goals from these values categories.
What's striking to me about that list is that, so geriatrics, we talk about function, ADLs, et cetera. But on that list, there are a number of things that are sort of outside that traditional sphere, like spiritual health and well-being, like valued activities, which may be different. They may be leisure activities, right? Like going to the movies or
mostly
going to church.
Avocations or
hobbies. And that we need to sort of widen our lens to include more of this sort of bigger picture of a family of important values. That's really sort of brings it, again, I see a lot of parallels with Karen Steinhauser's landmark paper on factors considered important to patients near the end of life. Many of them are similar to factors that are identified on that list. Getting right with God, spiritual well-being, things like that. So interesting. So where do you go from? So where do you go? You've identified these families. What's sort of the next step in the arc of this research pathway?
So how do you bring it into a clinical context? That's the challenging part, and doing it within the scope of visits and payable, billable things, right?
Yeah.
So what we've done is right now we're at a point where we've been able to train health professionals and a range of different types of people. I'm sort of agnostic of who could do this. And it doesn't even have to be a health professional, but probably someone who needs a little bit of training to sort of facilitate this conversation of what the priorities are. So you start with conversations about values that are kind of global, and you start to narrow it down more and get it more specific, and the value then gets transformed into a goal. And it could be a value. So let's say, I really value spending time with my grandkids. I really value independence to be able to get around to shopping or to go visit my grandkids. I really enjoy playing with my grandkids. So that gets transformed into a specific goal of, so twice a week, I'm going to go for 2 hours. I'm going to drive to my grandkids' house, walk up 3 flights of stairs, and be able to play with them for 2 hours. And that's a very specific, reasonable, measurable goal.
A smart goal.
A smart goal.
A specific, measurable,
actionable, realistic, and time-bound.
God, I always screw up the mnemonic.
Now, the reality is it's actually hard to get to SMART goals in clinical visits, so they don't have to be SMART right away, and iteratively they can get smarter. But just get to something that's specific to that person and actionable to that person, and start to work from there. And then the other big part of this is actually care preferences. So what you're willing and not willing to do. That's where the burden comes in. So it's really important so this facilitator has the values conversation, transforms the value into a goal, and then talks about care preferences, what you're willing and not willing to do to get to that goal.
And then the next step is where you double the metformin and add the glyburide.
So almost. So you're getting there. So right now where we're at is there's a note that can have values, goals, preferences, and it can go into the EMR, and then you give it to the clinician. And the clinician has to be a little bit trained about what the hell is all this, and how does this actually impact my diabetes and hypertension and all that. And so where so iteratively I'm trying to work on this myself in clinic. So if I get a list like that, or if I elicit it myself during clinic, how can I transform? Here's the magic. How can I transform the assessment and plan? So it's not this system disease focused approach, but one that actually says my goal is to spend 2 hours twice a week with my grandkids being able to do those activities. And then, so what are the conditions that are limiting my ability to that? What are the things I'm willing and not willing to do to get there? And then what's the doubling my metformin or increasing my Lasix to help me do that?
Right.
So it's interesting. So usually when I think about, like, in my work, like, I elicit values, things that they worry about, and kind of go back to align with those things to come up with a bigger picture kind of goal or view of where we're going with this person's care, like what's important to them. This feels a little bit in the opposite direction, where the goal isn't the bigger picture, but the goals are very specific, attainable. The SMART goals are almost, like, in my head, like the objectives. So you have the goals and you have the objectives, and these are very, like, SMART objectives. Is that how you think about it?
Yes. Yeah. So the funnel is at the top is values, broad, vague, not so specific, and then you come down to a specific outcome goal, and then how do I get better at attaining that outcome goal? I might need to titrate the Lasix, or I might need to add some other medication or services. I might need to bring in a home PT, to help them to do that. So those are the things that help you to attain that goal.
Right.
That goal.
Right, or environmental modifications, putting in a lift or something to get
services,
up those stairs,
supports,
or
care, all those things. Yeah.
Do you think we can do a quick role play on, like, how you would actually? Because I'm trying to figure out how you would actually do this. This is for, like, primary care clinic, right?
Yeah.
Then wait, before we do that, who's doing the values assessment? Is it the primary care physician?
So I think that's an empiric question. So right now we've found in the papers that were in JAGS, we talked about training a facilitator. So I have had facilitators who are nurses, social workers, psychology interns. So I'm sort of, again, agnostic about who can do the facilitation. But they do the facilitation, and it's a dedicated visit. And it produces a note that goes in the EMR. And then the clinician gets that note and then tries to align care to achieve those goals within the context of their preferences.
But the first steps, the conversation about values and bringing it down to specific achievable goals is conducted by this facilitator who is not a primary care physician or primary care clinician.
Or maybe, right?
It could be. So I'm trying to do this myself in clinic, where I elicit. You just need time. That takes more time.
How much time does this conversation take?
So the facilitation, once you have someone who's trained and has been doing it well for a while, can be done in 20 minutes.
20 minutes. All right. So I still want to know, like, some basic things. Is now an okay time, Alex, for a little role play?
Yes, it's an okay time, but we don't have 20 minutes.
I don't have 20 minutes. So we're going to skip and fast forward things. So
abbreviated
I want to go to the values. Like, how do you elicit people's values?
So through this process, we have actually developed some manuals that guide it, but this is not supposed to be manualized. So once people get really good at being a facilitator, I don't think they ever look at the facilitation manual. But it starts with, again, those values families. So So tell me, Eric, a little bit about friends or family that are really important to you, or some community activities, or even your spiritual practice. What's really important to you?
Podcasts are very important to me. I enjoy doing them with Alex here. Family. 10-year-old son's important to me. My wife.
Yeah, and so what, are there certain things in your health that gets
Good, you
in
got
the way?
wife in there, by the way.
Thank
Yeah,
you.
good, yeah.
I'd like to thank the Academy members.
So is there certain things that keep you from doing a podcast on a regular basis that you'd like to get some help with addressing those limitations?
I want better equipment. I have equipment envy. I want better microphones and.
Will Medicare pay for that as a
No.
home health service?
Okay, stop. Let's fast forward. What's the next question that you would ask me? Like, is there another? Do you talk about worries? Like,
Yeah.
is something we talk about often in palliative care.
We talk a little bit about worries, but I think it's so where the kind of the anxiety and worry part is there, but often it's a burden. So what's getting in the way of accomplishing some of these activities, and so it's often symptoms then, right? So it's back pain or shortness of breath or just I have to take too many pills, or the pills make me dizzy when I'm walking around, or they make me pee at night all the time. So that's where the preferences part can kind of come in at different times. Sometimes it's difficult to initiate this values conversation because they're just so fixated on this particular symptom. That's why they're here to see you. Mm-hmm. So you sort of start first with the preferences conversation of, so tell me a little bit more about this symptom you're having. And so then, what is it keeping you from doing that you really like, or what would you be doing more of if you weren't having that particular symptom? And then that starts to get in the conversation of a value and a goal.
So preferences. When you say preferences for
care preferences. So
care preferences.
Again, what you're willing and not willing to do in terms of your care, what you're willing or not willing to receive. So what is burdensome to you that you don't like doing, or
how do you ask that?
So there are different sort of set prompts that we guide at. So is there any aspects of your care that you find particularly burdensome or a hassle, or are there some medications that you haven't been taking even though they've been recommended because they're causing some problems that you're describing? So you're giving people room to complain about,
right?
Their recommended care.
So I'm just thinking, if boiling it down, if there are like 3 key questions that you could share with our listeners to launch them on the journey of having these conversations, what would they be?
So I think because they come in often with a driving symptom, I think you're never, so pain is often a key one, right? And so you're never going to make the pain go away. And that's often a lot in their head, is that, I'm having this pain, I just want it gone. So I think you ask a question that points it in a couple of ways. One, you want to get at a goal, and 2, you want to get them not so fixated on the pain going away. So I appreciate you're having a lot of pain on a daily basis. Can you tell, if we could make the pain a little bit less, could you describe something you'd be able to do more of, or you'd like to do more of, if we could get your pain a little bit better controlled? Tell me what that would look like. What would it look like on a daily basis? Something that you would like to be able to do.
Great. So that'd be the first question. And then the second question would be, let's say they respond, they'd like to go play with their grandkids, and they have to climb.
So often it's going to be a not so smart. It will be a value. It'll be vague. So you want to push them. So
play more.
So tell me a little bit what would that look like? On a regular basis, on a daily basis, or a weekly basis. So it's a matter of then iteratively teasing that out through the interview of of what does that. So you want to be able to. So when do you normally play with them?
Yeah.
How long does that take? There's some symptoms. What gets in the way of being able to do that a little bit?
So it sounds like first step we're talking about values and priorities.
Yeah. So my preference is to start with values. But sometimes you're struggling with getting to values because they're so fixated on a symptom.
Yeah.
So you kind of go. You have to roll with what comes to you in that setting. So if it's something symptom, then you go there and you try to transform that symptom into a goal. But if they're not focused so much on symptoms, we have these sort of set prompts on each of the values to talk about, what's really important in your life. And again, they're usually vague and broad. And then we try to narrow that down into, okay, so let's talk about a specific activity that you would be doing regularly that would show that you're living according to the value set.
Yeah.
So you really value this relationship with your colleague that's really creative. What would that look like on a daily or weekly basis? So we maybe get to the podcast.
Let's not get out of hand. Daily with Alex? I'm not sure.
Once a week.
So, okay, I'm just looking at your JAGS paper. So we the first step with the facilitator, we're talking about introduction to health priorities, values, that clarification process. Real quick, do you also suggest things? Because you also identified other things in your past papers, like spirituality being a very common source of values for
So
them?
I actually think all 4 or 5 of the values families are important. So this is a little bit of behavioral economics. So I think that we have, in a given visit, there's availability bias. So you're going to talk about the one value that's really on your mind at that moment.
Yeah.
But we found that actually all 4 or 5 of them are important. So if you have the time and the space, it's really good to try to elicit from each of the groups and try to identify.
Remind me, what are they again?
Yeah, social spiritual connections, number 1. Number 2 is kind of function independence, self-sufficiency. Number 3 is valued life activities or abilities. So that's the hobbies and the vocations and vocations. Number 4 is really the balance between quantity and quality of life. So how much do they value kind of prevention and how much do they focus on a particular symptom or quality of life issues? And the last one is the degree in which they want to be autonomous versus passive in their care, like their degree of engagement they want to get into.
Well, it's fascinating because probably also if you talk to physicians or sons or daughters of older adults, safety is not one of those 5 things, but something that all of the other people, I always hear, it's not safe for them to go home, or it's not, but that was not brought up in one of those 5.
No, because we elicit these from the patients themselves, right?
Right, not from their adult children.
Or they're from their providers.
Right.
So some of this has got to be realistic, right? So I think that's where a lot of the safety issues come to play. It's not real. So driving often is something they value.
Yeah.
So that's actually a good example. So their goal is to be able to drive, and then that they're just never going to be able to drive. So I'm going to credit Lillian here. So she's done a good job of saying, well, when you're stuck on a goal that's just completely unrealistic or unsafe, then that's where the values are helpful. So why do you care so much about driving? Is it about a social connection that you want to make, or is it about a certain particular activity you want to be able to do? So then, once you understand what the underlying value for why you want to drive, rarely is it just the act of driving, though sometimes it is just the act of driving. You identify the underlying value that the driving facilitates, and then you try to make a goal. So that's where Uber could be helpful, or that's where someone driving them to
paratransit.
Yeah, yeah.
So that's terrific. You go ahead, Eric.
Yeah, so I'm just trying to go through the 4 steps that you outlined in the JAGS article. First, we're identifying values. Second, that we're work as a facilitator, adapting those values into goals. Third step
is then make sure that you talk about the preferences, what they're willing and not willing to do. That's where trade-offs happen sometimes. So sometimes 2 goals conflict with each other, or a goal or a preference conflicts with each other. You got to get that out in the open. Otherwise, you're going to just... This is where all the quote-unquote non-adherence comes from, is people are voting with their feet. They're not going to do this because of the trade-offs.
I want, to have really tight blood sugar control, and I don't want to take any medicines.
Or I don't want to get dizzy when I'm walking around, which is what happens when you're on tight blood pressure control, right?
And how do you navigate that? How do you navigate the balancing?
So the first thing is just to bring them out to the surface and say, well, we're going to have there's some issues around trying to control your blood pressure to reduce your stroke risk, because you also said you really don't like all these medicines that cause you to feel dizzy. So you have to have the conversation of, this is what it comes out. So that's where getting the goals to be a bit more specific is helpful, because then that's where, you say you want to be able to lower the blood pressure down to a really safe range, but then be able to still walk 3 blocks without getting dizzy. So we actually haven't been able to do that for 3 months now, because every time you get your blood pressure that controlled, you do get dizzy when you walk. So you have to then talk to them about, okay, what is the blood pressure number you could get to that makes you less dizzy, or what are some medications we could change so that you get less dizzy.
Mm-hmm.
So it's actually, that's why I think the specificity and the actionability of the goals is important, because that's where you do titration of treatment.
And is that the fourth step?
No,
or was that the third?
fourth step was encouraging patients to communicate their health priorities.
Yeah, so then this is, in our paper really focused more on just the facilitation step. So it doesn't even get into actually as much of the care alignment activities. That's more stuff we're going to write about. But so, you know, so especially these conversations happening with a facilitator and not with your clinician or your PCP, you're hoping the facilitator has a conversation with the PCP. But I think it's really important for the patients to be able to also be their own advocate, and be activated on what their goals are. And if they don't sort of understand and embrace their goals, it's not really their goal. So I think that's an important part of this, is making sure it's part of that conversation they really embrace that this is their goal, not the goal that the doctor or the facilitator came up with.
Mm-hmm.
And so the fourth step is really for them to own the goal and embrace it and take it with them to their other visits.
So there's a component of this that's really about patient activation.
Yes.
Get patients motivated to sort of clarify and understand what sort of actionable goals they have, what their values are, and then bringing that to their providers.
I think it's an emergent property of the whole process.
Mm-hmm.
I don't know that I'm not even so sure that an activation scale would actually capture it. But I think it's just something that actually happens over time with this process.
So here are a couple questions. One is, does prognosis enter into this?
Yeah, so that's where you've got to think about what's realistic. So I think prognosis is very important. I think you're going to be more effective at this as a facilitator or the PCP if you know what the prognosis is, if you know what the current functional status is. If you have the patients understand, I think part of this process also helps them to appreciate maybe where they are in terms of their prognosis, or what is their illness trajectory over the next 5 years. So maybe the goals that they've come up with really don't reflect what their illness trajectory is.
Mm-hmm. So should we, because often what we do in palliative care is first, before we go into goals of care, we talk about illness understanding, prognosis understanding, preferences around that, and then talk about values in the context of what's happening with their health.
So I think that's one of these distinctions between the context of these conversations and the context of palliative care conversations.
Yeah.
I'm going to argue that it's easier to have that conversation in a palliative care visit than it is in this one, because again, you don't have that nidus of this serious illness or this terminal illness that's focused everyone on this conversation.
You have people with diabetes, COPD, hypertension, osteoporosis, but there's no...
And sometimes they know that their life expectancy probably isn't more than 3 or 4 or 5 years, but sometimes they think they're going to live 20 years, even though they're 85 with all these conditions.
Mm-hmm. Right, you do get quite a variation. We've done some research in this area, and most people tend to know that they're in the last quarter of the game when they have multiple chronic conditions and they're over 80 years old. But you do have the few outliers who are, I'm good for another 20, 25 years, when that's probably not the case. And then you have some other people who are actually hoping that their life ends sooner than it probably will. Which brings me another question. When it strikes me that sometimes what stands between the patient and accomplishing their goal is sort of a lack of motivation, and it may go all the way to a formal depression diagnosis, but sort of apathy and demotivation, demoralization. I'm wondering if these sort of more psychological factors have come up in your research.
Yeah, so we have in a different set of work, we've done some collaborative goal setting in comorbid diabetes and depression patients. So they have like PHQ-9 scores that the mean was 15 and their A1Cs, the mean is 9. And we've actually been doing telephone interventions that use the same principles. And the thing that actually improved the most was actually their depression scores, because this process does a lot of behavioral activation.
Mm-hmm.
It helps them identify a specific activity or behavior that they would like to do more of, and they're more inclined to do it. So
that's interesting.
Maybe another emergent property of this process is some internal motivation.
Yeah.
But clearly behavioral activation.
Right.
So it's motivation on a specific activity or task
Right.
that they want to do more of.
They want to do more of them. When you're doing activities that are more meaningful, when your life is more filled with meaning, then you may be happier, less depressed. Another question is, this strikes me as similar in some ways, in some respects, to the conversation guide that, so you mentioned Atul Gawande and the Being Mortal book, and this is something that's come out of the whole Ariadne Labs and Susan Block and Rochelle Bernanke. Can you talk about differences between this approach and the conversation guide approach?
So first of all, I'm big fans of their work, and I think that I think we came from different places, but we've probably come to a place that has a lot of overlap and similarities. So the conversation guide has some similarities to what we've described. I think we're probably a little bit more deliberate and specific on the values driving to specific goals, and they've talked more about. I think that they do a good job of bringing in this issue of worries and anxiety more upfront, and then focusing on that one activity that you want to do more of. I think has been a good focus of that work. So it'll be interesting to see how it kind of plays out over time. But I think that the context. So I think this is where we start this conversation on. The context of a palliative care conversation is different than the context of these conversations, and that produces differences in outcomes sometimes.
Mm-hmm. Yeah, my understanding is they're pushing into primary care settings, and I've actually tested it in a number of primary care settings. Although, as you say,
but they're still usually serious illness patients.
Their criteria for entry is a limited prognosis.
Yes.
What's next for you?
So we are doing some more work on the next step of this. So once you've got the facilitation piece done and you have these goals and preferences written out, how then do you help the clinicians align care in a feasible way? So I think I know how to do this esoterically. If I had all the time in the world and I was in a research lab, I would know exactly how to do this, but we're not. We're in the real world where you have limited time and visits, and so efficiency and feasibility of it. But there's also a perspective change that's required too, and I think a lot of clinicians fight this because they were just so trained on disease-based work and breaking things down into systems and guidelines drive so much of what we do nowadays. So actually, none of this is against guidelines, against evidence, against disease process. In fact, you have to understand physiology to do this well. But how do you do that process of taking a set of priorities that were given to you by a facilitator or that you did yourself, but then aligning the assessment and plan in a typical visit? That's, I think, the next challenge.
Yeah, it's almost like you need to go back and retrain the medical students and the nurse practitioners starting from the beginning. And, well, let's say, how would you change the way you think about managing a patient based on these particular goals going forward, rather than this particular disease, and trying to reduce morbidity and mortality from this particular disease.
But knowing that the disease is there and what its ramifications are, implications are physiologically, you can't get away from that.
Right,
That's
you
still
need
really
both.
important.
You need both, but the approach starts with the
Yes.
values and the goals rather than with the disease.
Yeah.
So we are going to have a link to your JAGS paper on our GeriPal website. I want to thank you for joining us today. Absolutely fabulous discussion and coming out here to San Francisco.
Thank you so much. This is great.
Thank you for inviting
You're
me.
doing great work. How about we end with a little bit more of the Lumineers? Not Alex doing the Lumineers. We don't.
I'm not the Lumineers. And I don't have a sweetheart yet, but if I did, I'd break my neck. Please Please her, make her wanna stay in my arms, she'd rest. But I don't have a sweetheart yet. I can't believe what I found in Daddy's sock drawer today. It was a pistol, a Smith & Wesson, holy shit. La 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 la. La 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 la.
That was lovely. With the cursing.
Well, I want to thank all of our listeners for joining us. Please stay tuned for our next Jerry Pal podcast. And if you have a moment, please take a moment to rate us on your favorite podcasting software. Goodbye, everyone.
Bye. See you next week.
Thank you.